smoke cigars and drink scotch. So certainly a big loss for me personally, because Ed and I, we've just become the best of friends. And as you know, Shiv Kumar tells me correctly, Ed is my American brother. So you know, there's a lot of love between us. But regardless, what he has done at UCSF is just remarkable. Just within the last 7-8 years, he established a preeminent program in VT ablation on the West Coast. The fellowship program that he now directs gets fellows internationally from all over the world. And some of the people that have come out of the program, they're already kind of making a name for themselves. Ed's interests are multidimensional, and obviously his training, he's able to support all of that. So his background is in signal processing. He can write computer programs. He has a very, very keen understanding of statistical analysis. And all of that he has harnessed in so many different ways. So the work that he has done with defining the mechanisms underlying AF, obviously that's work on itself. And then more recently, he has really developed this niche in understanding the cardiomyopathy, which is perpetuated by Pvcs, and the porcine model of PVC-mediated cardiomyopathy that he has created provides us some very unique insights, not only in terms of the clinical manifestations, but some of the underlying mechanisms. And so I'm really grateful that Ed has agreed, number one, to wake up this early to participate in the webinar, and then more importantly, give us this time to both talk to us about PVC-mediated cardiomyopathy, and then also provide us some guidance on his experience with pulse field ablation. So Ed, thank you again for doing this, and please take it from here.
Well, thank you, Sanjay, and thanks so much again for that kind invitation. I'd say I really also miss our camaraderie at Penn, and the other thing that suffered is my tennis game, which doesn't get as much play these days. But yeah, it's a pleasure to be here, and obviously everything we do these days seems to be remote. And Sanjay's told me that everyone here is either an EP or an EP in training, so I've tried to steer things hopefully, and hopefully you'll find it interesting and of use. And happy to take any questions in between at the end. Not much in terms of conflicts. Medtronic donated some of the pacemakers and leads for the animal study. So I think we all know, among certainly EP group, that PVCs, when they're frequent, can lead to a cardiomyopathy. I often start with this study that was by my colleague, Greg Marcus at UCSF, which is as close to a prospective study as we can get, which was, he looked at 1,139 patients in the cardiovascular health study who had baseline normal heart function, no structural heart disease, no prior heart failure, and had baseline 24-hour Holters, and then were followed for 5 years. We could collect all the follow-up data. And as we know, we found that the baseline PVC burden not only predicted, or was associated with, I should say, incident heart failure, but also was associated with an increase in mortality. And when you look at other common predictors of heart failure, BMI, hypertension, age, coronary disease, PVC burden was kind of on par with those. But of course, this is it's an epidemiologic study, so it's showing an association. It doesn't prove causation. And but what it suggests, maybe PVCs are more of a problem in the general population when it comes to causes of idiopathic cardiomyopathy. But then I also like this study, which was the senior author's Mark Dale, who was also a former Penn Fellow who works now up in Canada. And they started a PVC registry when he got there. So 194 patients with more than 5% PVCs, and they excluded anyone with any kind of cardiomyopathy or structural heart disease. So they ended up with 100 patients with normal heart function and frequent PVCs. And they actually just followed them. They didn't do anything. And I thought it was interesting that, it's kind of a regression to the mean, but what they saw over time was that many patients just got better on their own. So of the 100 patients, 44% had a resolution to less than 1%, and generally over about a 15-month period. Another 52% had an 80% reduction over about 14 months. And there are about 4% who ended up developing a drop in EF. If you look at the patients who, the 44% who dropped to less than 1%, there were another 9 or about 20% who had a subsequent later increase. So, from this study, it means you probably do need to keep an eye on people, but some of the time, again, I always tell people when they first present, because that's usually going to be at the peak, the PVCs may get better on their own. So it's not that we necessarily have to rush every, especially asymptomatic person with frequent PVCs to the lab for ablation, but we have to keep an eye on them. And the other thing the study pointed out is, the decrease in EF over time that occurred, was over 60 months. So it's not like people fall off a cliff if you follow them. The drop tends to be gradual. So this maybe suggests that PVCs aren't such a bad problem, but you have to identify the people that you need to follow a little more closely. And then this is a study out of Penn. It's a smaller study, but again, it's the thing I like about it is it's prospective. So about 45 patients who had a normal EF and were frequent PVCs who were kind of followed waiting for their ablation. So 45 patients followed about 14 months and a little higher number. So 17 developed some drop in their EF. And what was the biggest predictor was the QRS duration of the PVC. So wider PVC is more likely to develop a cardiomyopathy. And interestingly, and I'll show you some of this in our animal data, the sinus rhythm QRS actually was wider in those patients with a cardiomyopathy than in normal EF. We'll look at why that might be. So again, a lot of this data shows an association of PVCs, and a lot of heart failure docs took time to come around. The question is this just some people who have some underlying kind of form first of cardiomyopathy and PVCs, and the PVCs are an epiphenomenon. Obviously, the Michigan group, let me go through that data, shown ablating the PVCs, the EF improves, so it clearly is causative. But we thought we would try and see if we could set up a model, an animal model of PVC cardiomyopathy, because with humans, obviously, you get what you get. Most of the PVCs are outflow tract or septal, and we wanted to try and understand more about why this happens and what the mechanisms might be. And so we did it with a swine model, we took a standard dual chamber pacemaker, but we put both leads in the ventricle. So one lead was sensing, and that was connected to the atrial port, and the other lead was for pacing and connected to the ventricular port. So then by setting it just to the VDD mode, so we're sensing, the pacemaker thinks it's the A, but we're sensing the intrinsic ventricular beat, then we can deliver a paced ventricular beat, essentially a PVC, and create a 50% PVC burden. Right? And by varying the AV delay of the pacemaker, we can vary the coupling interval between the prior sinus beat and the PVCs. Then we can look at, by moving the location of somebody needs to mute, there you go. By moving the location of the lead, we can look at the location of the PVC, and by changing the AV delay, we can look at the coupling interval. And at first we didn't know if, who knows if in a pig over a few months, this would actually work. So we had 10 animals that we created 50% PVCs and 5 that were controls. So we inserted pacemakers and leads, but had it just on a sensing mode. We didn't do any pacing. Wanted to have some leads across the tricuspid valve so people couldn't say, well, maybe this is just due to TR. And this is, echoes in pigs are not so easy, it turns out. So it's different than we're used to seeing, sort of a left-sided, left lateral view. The RV is underneath the LV. It's kind of the baseline echo in a normal pig. This is during the pace by Gemini. You can see this kind of a hitch in the contraction. And then this is one animal after 14 weeks. And I think if you look compared to baseline, you can see that the LV has dilated a bit, and that the function is clearly reduced. And this was always, measured in sinus rhythm, the LV function, not with the PVCs. And this is the data, so control animals without pacing, and then the PVC animals. You can see there is, a fairly wide error bar on these. So there were some animals that dropped down to 30, really had smoke in their LV and echo, pretty bad, and some were just a mild cardiomyopathy. But clearly, this is end-diastolic, end-systolic dimension. We saw dilatation and a drop in EF. that seems similar to what we see with human PVC cardiomyopathy. And again, all these time points, the pacemaker was turned off for 10 minutes, then the echo was done. So the echoes were done in sinus rhythm, and then the pacing was turned back on. This was done by Dr. Tanaka, who was a Japanese fellow, spent a couple of years in the lab. We also could look, histologically at these animals, and what we did see was kind of a diffuse, mild but pretty diffuse increase in fibrosis, and it was throughout. So this is apicolateral, basolateral, apical septal, and basal septal sections, and the fibrosis was everywhere except wasn't really increased for whatever reason in the basal septum. And it seemed to be, more severe in animals with more severe cardiomyopathy. So it seemed to be a model that mimicked PVC-induced cardiomyopathy. And we also looked at some calcium handling molecular changes. I'm not going to get into too much detail. But then Dr. Walters, who was a subsequent fellow, did another larger study once we showed that the model worked, because we wanted to look at PVC location and how the PVC might affect the cardiomyopathy. So he looked at 5 groups of animals, one with PVCs from the RV free wall. We had a fixed coupling interval of about 320 milliseconds. It was long enough that the lead would constantly capture. And then we had another group of animals where we put the lead through the coronary sinus to the lateral LV epicardium, so essentially bad bi-V pacing to create the synchrony at the same coupling interval. There's a third group of animals with PACs at the same coupling interval, so mimic the irregularity of the PVC without the dysynchrony by having a narrow conducted QRS. There's a control group with no pacing, and then we wanted to see whether, a lot of people said, well, isn't this just a tachycardiomyopathy model because the average heart rate is faster? And so when we put patches, actually, patch monitors on the pigs, their average heart rate with the PVCs was around 130, 135. So we had a group of regular pacing from the RV at 140 to distinguish, see if it was different than the irregular group. And then we had one more group of 5 animals that he paced from the LV to create the cardiomyopathy and then stopped for 4 weeks to let them recover. And again, we looked at histology and molecular evaluation. This is just showing some of the leads. So this is pacing lead at the RV apex. Again, it's a pig. The fluoro is a little bit different than we're used to, but this is RV free wall. And then again, our fellows have become really good at putting an LV lead in pigs, which is not so easy. So this is a CS lead pacing from the LV epi PVCs. And we use the conductance catheter. It's a pressure volume loop catheter, because it really is hard to measure dysynchrony on single PVCs with echo in pigs anyway. And this is the dysynchrony at baseline in sinus rhythm. So not much dysynchrony, less than 5% by this measure is pretty normal for the PAC group, the RV group, and the LV group. And this is actually the synchrony created by the individual PVCs. This is not in sinus rhythm. And you can see that there's a little, not much dysynchrony in the PAC group, but the RV PVC group had kind of a modest increase in dysynchrony, and we were causing the most dysynchrony with the LV epicardial PVC group. And this is kind of the summary slide looking at the change in ejection fraction on the y-axis over time. So the control arm, again, no change in ejection fraction. Both the regular 140 beat a minute group and the PAC group, you could say maybe there was a mild drop, although again, the EF was still around 60, but you could see the RV free wall PVC group clearly had a bigger drop, and then the biggest drop was in the LV epi group. So again, this argued, I think, that this is not just a tachycardiomyopathy, or not just due to the irregularity, that the location and the synchrony of the PVC, much like we know left bundle branch block leads to a cardiomyopathy, can contribute to a cardiomyopathy. And when you plot this as a correlation, you'll see that certainly the more dysynchrony of the PVC, the greater the drop in EF. So we think the QRS width and the dysynchrony the PVC creates is a big part of the process that leads to cardiomyopathy, and why it does that, again, we're still trying to figure out. I thought this was interesting. So this is actually the sinus rhythm QRS, if you remember that Penn study I showed you at baseline in black, in fuchsia at 6 weeks, and blue at 12 weeks. And what you see on the LV epicardial group is that the sinus rhythm, again, these aren't big QRSs, usually about 60 milliseconds, but the sinus rhythm group, the QRS actually did widen. And we think this is likely related to the fibrosis and slowing of conduction. We're doing mapping now to look at conduction velocities, and there is some slowing of conduction velocity with the PVCs. As we saw with the pilot study, compared to the controls in the PAC group, we see the RV and the LV epi did have a significant increase in fibrosis, both in the LV and actually in the RV as well. And then then we took the 5 animals where we, after 12 weeks at this arrow, we stopped pacing. We wanted to see, what happened. We stopped pacing, and, not surprisingly, over the next month, the EF comes back up to normal. But interestingly, the fibrosis, while it improved, was still elevated after a month of sinus rhythm. And again, some people argue, which is true, maybe we should have just waited longer, maybe if we wait 2-3 months, the fibrosis would all resolve. But it does argue, I think, that even when you have patients with PVC myopathy whose EF recovers after, say, an ablation, there may be some persistent structural abnormalities that stick around, at least for a period of time. Maybe we shouldn't, stop all their medicines right away. And the other thing, I think, again, that we're still trying to explain, but is interesting. So this is the synchrony measured in sinus rhythm, not of the PVC. So in the control group, baseline in 12 weeks. The LV PVC group, again, here we're in sinus rhythm, so we stopped pacing. So even in sinus rhythm, there's what I call dysynchrony memory. So the LV contraction in sinus rhythm, when you stop the PVCs for 10 minutes, continues to be dysynchronous. I think it's analogous to T-wave memory, where the structural changes that have happened heterogeneously take some time to resolve. And in this group of studies, even after a month of recovery, this synchrony persisted, so it can stick around for a while. So again, and perhaps that's related to the fibrosis, but it's interesting, again, that and maybe that's why you don't need a super high burden, why sometimes 15-20% PVCs can lead to a myopathy is, even in the sinus rhythm beats, they'll kind of infer some desynchronous contraction. So from the model, we saw that this model with 50% PVCs, mimicked the human PVC cardiomyopathy. It was associated with increased fibrosis. The worse the dysynchrony of the PVC, the worse the cardiomyopathy. That PVC cardiomyopathy is a distinct entity from tachycardiomyopathy, just rate-related cardiomyopathy. And that after 4 weeks without PVCs, the LV function recovered, but the fibrosis and dysynchrony persist. Okay, so I wanted to jump because I know we're more of a clinical audience to kind of how we clinically manage PVCs. I think we all do all the time. And this was, I think, sort of a small clinical point that was interesting from one of our studies. So this is about 200 people who wore a 2-week continuous patch monitors and looked at daily PVC burden. And the blue, this is all the patients in the x-axis. And the blue is the lowest daily minimum burden. And the red was the highest daily minimum burden. Because again, I think in the past, people had used 24-hour Holters a lot. I think nowadays we're using longer-term monitoring more, but it just shows you, if you look in blue, if you happen to pick a certain day, you may have a very low PVC burden of maybe 2%, but in that same patient, on other days, they're getting up to 15-20%. And in fact, the maximum burden we found was a better predictor of cardiomyopathy than the minimum or even the mean. So again, it just shows you, even out here where you've got people with a 20-25% burden, they may have days that are much lower. So looking over, I think a 7 or 14-day monitor, looking at daily PVC burden, I think can be more helpful as opposed to a 24-hour kind of snapshot when you're trying to look at therapy and potentially risk. And we all know the options. So, if someone's got a low burden and normal heart function and they're asymptomatic, generally just kind of reassure them, burden under 5% to say, if they have a high burden, often if we're going to try medical therapy, we'll start with beta blockers, usually metoprolol. I found just, clinically this Sectrol or acebutolol, I don't know if that's available, but that tends to actually work pretty well for PVCs. And if people feel tired on metoprolol, we've used that. Mexilatine I've used rarely. It's sort of a benign drug that sometimes can help. Often if people don't have structural heart disease, the drugs that work best are flecainide or propafenone. Obviously, in structural heart disease, you could use class 3s. And then obviously we all like catheter ablation. The question of 1Cs, I think, comes up a lot. So if you have someone with a PVC cardiomyopathy, does that count as structural heart disease where 1Cs are prohibited? At least in the US, kind of medical legally, there's a black box warning on flecainide, since from the CAST study that it should not be used in people with any structural heart disease, and that decreased EF people have attributed to that. So I've used it in the past in people with a mild cardiomyopathy that we think is just PVC related because it works so well, but there isn't much data supporting that. But this was actually a study from Penn, Sanjay's on there in the middle, and they looked at using 1Cs, flecainide, typically, or propafenone for PVC suppression in patients with a PVC-induced cardiomyopathy. So they importantly excluded people with SCAR based on MRI or structural heart disease. And some of these patients actually had external defibrillators, or some even had internal defibrillators. But what they found when they treated these patients with 1Cs is a dramatic reduction in PVC burden from 36 to 10 and an improvement in the EF from 37 to 49. Over about 4 years, there were no VTs or sudden deaths. So it's, it's a small group of 20 patients, I think at least provides us with some reassurance that if you have someone with no SCAR by MRI, say, and what you would attribute to be a mild, PVC cardiomyopathy who wants to try medical therapy, that something like flecainide is an option. This is a study from Berruezo, just making another point with PVCs. At least in the US, ejection fraction less than 35% is a potential indication for prophylactic defibrillator implantation. And so they looked at 66 patients who all, met primary prevention criteria on medical therapy and ejection fraction less than 35%, who had frequent PVCs. They ablated the PVCs, and not surprisingly, as we know, only about a third of the patients after a year actually were remained eligible by EF criteria, because, as shown on the right, for non-ischemics in red and ischemics in blue, you often saw an improvement in ejection fraction, even in patients with a pre-existing cardiomyopathy. So certainly our heart failure folks and us as electrophysiologists have become much more aggressive in terms of screening patients who are referred for primary prevention defibrillators for PVCs that may be amenable to ablation, and hold off on the ICD to see what happens over time. Another common question that comes up is, how much PVC reduction with ablation is enough? Because, sometimes you go in and there's 3-4 different PVCs and you have to ablate every one. This was another study from when I was at Penn. It's Stavros Mantavanatos is a fellow who's in practice in the US now. And, he looked at 3 groups of patients, a group of patients who had PVC ablation with no or rare PVCs afterwards, a group with 80% reduction. So they still had some PVCs, 20%, but generally the burden was less than 5%. And then a group that had basically unsuccessful PVC ablation. And with the group with complete PVC elimination, you saw about a 13% improvement in EF, and a similar improvement in the group with 80% reduction, and really not much change in the group who didn't. So again, this argues that, we always argue that if you can get the burden reduced by 80% or less than 5% on a monitor, that's probably done a reasonable job. I always tell patients up front, you're not going to get down to 0%, but if you're less than 5%, the likelihood that's contributing to your cardiomyopathy is lower. And then I like to show, I think a lot of people have shown this kind of slide, is someone who came to the lab in by Gemini, and we had, a femoral arterial sheath in just for mapping. And, you can see that basically this PVC is not contributing to cardiac output, right? You see a narrow beat and a wide beat, and the narrow beat is causing the pulse pressure. There's really no effect from the wide beat. So, when we talk about symptoms for PVCs, it's not just palpitations, but some people will just have a relative bradycardia and feel poorly, and can feel better after ablation. So, we're sort of careful to question people and say, well, who's truly asymptomatic versus, some people just after ablation, obviously there's some placebo effect, but we'll say, hey, I really just, feel more energy, feel better. But the real question that remains is, so what about these asymptomatic, so truly asymptomatic patients with a high PVC burden, right? We're often referred these patients, and often their referrings are worried, and the question is, what do you do with these patients if their heart function is normal? In general, I would say we tend to recommend monitoring them, get an echo and Holter or some kind of monitor once a year, and if you start to see any LV dilatation or drop in EF, then to recommend ablation. As we know from that Dayal study, they if you follow them, they tend not to all of a sudden drop off a cliff. So that's probably the most common option. If they have a high burden, beta blocker, I think there's not a clear indication, but you often see a modest reduction, but occasionally I've seen dramatic reductions. And if they have other indication like hypertension, then we might try a beta blocker. One of the questions that I always was interested in is, can you sort of risk stratify these patients and say, well, you're really not at risk. We don't need to worry about you, but can we identify patients who are potentially at higher and lower risk? And that was a study that Alex Vaskobojnik, this is published in Heart Rhythm, did, which is look at our group of patients, so 206 patients who had a greater than 5% PVC burden and a recent echo over about a 5-year period. This is just the baseline numbers, so age of 65, some valvular disease. This is kind of their PVC burden. Average about 11%, minimum of 7, max of 18%. And, we looked at patients with and without a drop in EF or PVC mediated cardiomyopathy to say, were there factors that were associated with a PVC cardiomyopathy? And these ones in yellow were what dropped out. So we looked at lots of different factors. Male gender has been shown in some studies. In our study, it was close, so 0.05, but didn't come out as an independent predictor. Again, multiple morphologies, the coupling interval turned out to be close, but not significant. But these 5 factors, so the presence on a monitor of non-sustained VT, actually a long coupling interval. So in this study, coupling interval greater than 500 milliseconds, and this is the univariate and then the multivariate odds ratio kind of predictor of being associated with reduced EF. A superiorly directed axis, probably again because the QRS tends to be wider and have more synchrony. So a non-outflow tract, essentially PVC, had about a 2.7 odds ratio of leading to a cardiomyopathy. And then the PVC burden, so 10 to 20% had an odds ratio of 3.5, and greater than 20% had an odds ratio of 4.5. So you kind of put this together into a PVC risk score that you have to have a catchy name, of course, not as catchy as Rasta for Sanjay, but the ABC VT score. And based on the odds ratio, a superior axis gave you 1 point, a burden of 10 to 20 gave you 2 points, and greater than 23 points. The coupling interval greater than 500 gave you 4 points, and then non-stained VT also is a big predictor, gave you 4 points. And so then you can, that's Alex Vaskobojnik, who was an Australian fellow, who's back there practicing now. So what we did then is we took these patients who had, the group of patients, it was 134 who had a normal EF, no heart failure at baseline. And since these were up until 2017, Alex, then we followed those for another 3.5 years to see what happened with those patients over time, and how well this ABC-VT score predicted a composite future adverse events, which was mortality and EV-EF decline more than 10% or hospitalization for heart failure. And it turns out the score worked pretty well. So if your score was 0 to 4, you really did fine, had no problem over the next 3.5 years. And you can see the group that was 5 to 8, some of them started to have events, and the group that was 9 to 12 had more events. Importantly, this group 0 to 4 is about 85% of the patients. So again, I think clinically it's useful because at least you can say, if you've got an alpha tract PVC of 12%, your score is 1, and generally, again, the likelihood of running into trouble for that patient is pretty low. It's these higher groups that are having non-stained VT that perhaps you need to keep a closer eye on. We did sort of a validation cohort because one of our research fellows was Korean, and he said, oh, we have a big 500 patient database of people with frequent PVCs we followed for many years. And so we looked at the same composite over 4 years. And again, it's not split out quite as well as our initial group, but the likelihood of events in the 0 to 4 group was relatively low and greater than 4 predicted events. So, again, I think clinically I do this now to reassure patients that if they're in the 0 to 4 group, there's a low likelihood they're going to run into trouble over time. So again, this is not all PVCs are the same. So this is an alpha tract patient, inferior axis, 14% burden, shortish coupling interval, no non-stained VT. So, we can reassure this patient based on their Holter that they're low risk, whereas this patient has a superior axis, 22% burden, a long coupling interval, and non-stained VT. And, I don't think we have enough data yet to say we should necessarily ablate this patient, but I think it's someone we would keep certainly a closer eye on. And I have had patients where after, a year of echoes and monitoring say, I'd rather just be done with it and have it fixed if we think it's low risk. Obviously, it depends where the PVC is coming from. If it's, papillary muscle and is higher risk, we might not jump to that. But again, I think it's patients who you might keep a closer eye on. The other thing, we didn't have MRIs in all our patients. We couldn't really look at that. But again, this is another registry study. Dana Muser, Sanjay's involved in this, from Penn, looking at 518 patients who had frequent PVCs with an apparently normal heart, meaning their echo was completely normal, and they did contrast MRIs. And you'll see the majority, 84%, had a normal MRI. There was one resuscitated cardiac arrest, 0.2%, whereas in the 16%, the smaller group who had delayed enhancement or scar in their MRI, about 20% got ICDs. There was if you add this up, so 25, 30, so 30% of them ran into some kind of trouble with sudden death, cardiac arrest, or ICD shocks. Of course, a shock doesn't necessarily equal mortality, but I think that's another thing we use in the risk stratification. I don't get an MRI in a young person with a single morphology of a typical alpha tract PVC, but anyone who's older, anyone who's got more than one morphology, or a non-classic alpha tract morphology, we'll get an MRI on before ablation, because the patients with scar, especially if you can induce VT, they may have some risk, and even ablating the PVC may not remove that risk completely. So I thought, since this was an EP audience, I would just throw in some PVC ablation, perhaps looking at, we all obviously are used to RV alpha tract and LV alpha tract, but some less common PVC origins and some cases I've had recently and how we approach those. So Parisian PVCs, I think once, kind of like, it's you probably see a lot more of this, but in the States at least, WPW is like, we all get really excited if we see a pathway, right? Because the pediatricians have all ablated them, and it's very hard. As adult EPs, we don't see them. I think, the classic RV alpha tract PVCs that Sanjay and I saw as fellows, it may be different at Penn, but we don't see those as quaternary kind of UCSF referral centers, because all the private EPs in the community can ablate those. And so they've all gone away. And so the only ones I get are either the Summit LV alpha tract ones, or papillary muscles, or sometimes these Parisian ones that make people nervous. So we tried to look at a group of this. Obviously the anatomy we know the AV node is at the apex of the triangle of Koch, right, bordered by the septal leaflet of the tricuspid valve, the coronary sinus below, and the tendon of Todaro posteriorly. And the penetrating then bundle of His penetrates into the fibrous trigone. And the anatomy of the Parisian region is that this right coronary cusp ends up falling often right on top of that Parisian region, and is, this bundle of His, since it's inside the fibrous trigone, is somewhat protected. So I think this has been published and probably is known by many of you, but the right cusp can be a kind of a savior for some of these difficult Parisian PVCs when they're very close to the His on the right side. We like to use a lot of intracardiac echo for Pvc ablation. So this is just looking at the coronary cusps, right? The left, the right, and the non-coronary cusp. And you can see actually here the left main coronary artery. So we can put that all in our mapping system. And then, I like this view for alpha tract PVCs, because we know the His region is basically at the junction of the tricuspid annulus and the aortic root. So the His will be up here, and we know we come down. So this is left, right, non, and the left main coronary artery. And over here, we've got the right cusp, and then overlapping it, the left behind and the tricuspid annulus. So using this CardioSound is the brand, but using our electroanatomic mapping system, we can put in where the His should be at the junction of the tricuspid valve and the aortic root. We can draw in the right ventricular outflow tract and the coronary cusps. So again, we have all that anatomy nicely in our mapping system: the non-coronary, the right coronary, the RV outflow tract, the RV, and again, same on the left, the right cusp and non-coronary, the left. We can draw in the left main coming off the left coronary cusp. And then we can see the His. Again, you see, as we saw in that anatomy slide, that the right cusp often lies just above the bundle of His. And we can see the alpha tract pulmonic valve and the PA. So it's a nice way to kind of quickly get all those anatomic landmarks. And we know that, Sanjay taught us, right, when he was a fellow many years ago, 2030, wow, it's a while ago. The typical morphology of alpha tract PVC is from under the pulmonic valve, right, where they're high up a left bundle inferior axis. And one of the hallmarks is that AVR and AVL are both, deeply negative because they're coming from high up in the heart. And lead one, can be a little positive for posterior RV alpha tract and a little negative when it's more anterior, but the amplitude is generally small. So when we look at these Parisian PVCs, again, I think a lot of people are surprised when they go in there with mapping, when they just see a left bundle inferior axis PVC. But one of the hallmarks can be this AVL, right? When you see AVL, so these are PVCs that were ablated from either the Parisian region or the cusps or under the cusps. When you see AVL that starts to get flat, like this one over here on the right, are certainly positive. And then you see lead one, it's much more positive than you would usually see for an alpha tract. That combination basically means you've come from the pulmonic valve down towards the top of the tricuspid valve. So you're posterior and more rightward, and that will give you these stronger forces in lead one. And because you're less superior, the flatter positive AVL, those could be, and as well as the skinny PVC, could be clues that these are Parisian PVCs. And so obviously you can go retrograde aortic, and we can map the coronary cusps. This is the right cusp. You can see it's just above the tricuspid annulus in RAO and LAO. Another trick for some of these is to curl up into the LV underneath the right cusp. And we've definitely had some cases where we've been able to ablate the PVCs there. Once you go through the cusp underneath, you're getting very close to the left Parisian region, and then you can run into some trouble there. So usually we either are in the cusp itself or curl up underneath. And so this was someone I saw as a 19-year-old, actually, irregular pulse, minimal symptoms, but had 27% PVCs on a Holter, had tried metoprolol and just felt tired, as most young people do, had some VT on a stress test, and his echo was mildly dilated with an EF of 50 to 55. So at 19, we thought we should probably do something about this. And this is his EKG, which looks like a kind of a wide PVC. But again, in AVL, you see this, we also call it sort of a W pattern, flat kind of W in AVL, and how tall and positive it is in lead one. So even though it's a left bundle inferior axis, it's at the top of the tricuspid annulus. And honestly, looking at it, it's got this wide notched appearance in the inferior leads, and I thought it might be more on the free wall side of the tricuspid annulus. This was a sinus rhythm ECG, so certainly, no signs of ARVC or other cardiomyopathy. Talk about what to do with him, but he was 19 and didn't like beta blockers, so we ended up bringing him to the lab. He would have these bursts, little runs of this. So we mapped the right parahistian region, and this is a pace map, and this is the PVC. This is sort of pseudofusion. So pretty good, almost perfect, one could say, pace map from the right parahistian region. And we found a V that was pretty early, I think it was probably 28 milliseconds pre-QRS. But the catheter here is right above the His cloud in yellow. If you came back a little with the catheter, you can see this early is on the proximal electrode, the distal is a little bit later. But the other thing we saw was kind of a far field hiss that made me kind of nervous at a 19-year-old. So we went over, which is, again, the trick we've learned, to the right cusp. And here the signal is equally early. But again, you don't usually see this in the right cusp. You often don't see it till you go through, but we could still see a far field hiss, which sometimes you can see in the right cusp. And this is kind of the catheter location. So this is the His catheter in the tricuspid annulus. This is, we're really, not surprisingly, just above the His. And even though, again, we know that it's protected, that I haven't honestly seen heart block ablating in the right cusp, in a 19-year-old, it still made me nervous seeing a His there. But again, the guy clearly has some cardiomyopathy. Question is, what do you do? Do you just ablate cautiously at low power? You go back to the right parahistian site and ablate cautiously with RF. Would you do cryo from the right site, or cryo from the cusp, or stop and maybe just try a drug and see how he does? So what we ended up doing, and it makes me a little nervous to use cryo in the aortic root because we've seen some trouble, but carefully, again, just because he was 19, I put a 6mm cryo catheter into that same location. I've tried cryo from the right side, right parahistian, and haven't had a lot of luck. Maybe you've had different, other experiences. But as soon as we came on with the cryo, actually this PVC non-stain VT went away and ended up staying away. It's on a couple of months later. So I thought that was interesting. Again, one is just using the cusps and as a view of the parahistian region, and also potentially cryo when you're still close to the parahistian region. And then there's one other case I was just going to mention to highlight another useful technique for mapping summit PVCs, right? We know the summit is the superiormost aspect of the septum, and that this can be another challenging site for PVC origins. So this was a 61-year-old. He actually had been bypassed for coronary artery disease, EF of 30 to 35, had a PVC burden initially 15 up to 25% by his ICD, and was actually in 400 of amio. And someone else tried to ablate them and couldn't. This is his Pvc morphology. And, again, this is several characteristics we've known that always make us, we know it's going to be a more complicated case when we see these patients coming to the lab. So pretty early R wave transition, right? Already an R wave in the Pvc in V1. And what we call this pattern break, there's a little S wave in V1. There's not much S wave in V2, and there's a big deep S wave in V3, big deep S wave in V2. So this means it's coming, under V2, and along with, predominantly negative lead one, suggests an epicardial exit somewhere in this summit region. And, we try to avoid epicardial access for these just because it always ends up being difficult. There's fat, there's the coronaries. This is two different Pvc morphologies. Again, this one on the left that had this pattern break. They both did actually, but you can tell there were sort of slight variations on each other. And we know what we've come to use a lot is this little micro catheter. So it's MAPIT, it's called, but there's a couple of different variations on the market. It's a 3 French little multipolar small catheter that we can thread out the coronary veins. And this is what it looks like in fluoro. Again, this guy's had a cabbage. So what I actually like to use is an SL3 long sheath. It tends to point you at the CS. And then, this is just a floppy little catheter. So we'll typically use a 6 French multi-purpose guide, which is out here at about 3 o'clock in this coronary sinus. And then we can thread this multipolar catheter out. You can see it's really going all the way out the AIV and the septal perforators. And it's nice because even if you can't get your ablation catheter out there, you can record the earliest activation, and then you can map it adjacent and ablate at adjacent sites, which I think is the key for these Pvcs. This guy actually had some runs of VT, and we can get a quick look and see from the AIV 7-8 that we're getting pre-QRS. And so we ended up putting our ablation catheter out the AIV. And again, we were sort of fortunate that this patient had been bypassed already. So usually you worry about ablating the AIV being close to the LAD, but this guy's LAD was already bypassed, so it was kind of a protected AIV. We didn't have to worry as much. We ablated, again, the limitation often is you can only get sort of 25, 30 watts in the AIV. And even though it was relatively early, the Pvcs didn't quite go away. And, we use this trick that I think has been well described by Will Sauer. We collaborated on this. This was initially from pig hearts, showing that if you use half normal saline as opposed to normal saline as the irrigant, there's some controversy, but I think it does help. You can actually, concentrate the energy more into the myocardium because the milieu around it has a lower ionic content. And we found that, and we'll describe that the lesions can be up to about 30% bigger with that. And showed the subsequent study, again, that in patients who had refractory Pvcs, that were able to get about 80% success using half normal saline. Sorry. But you do have to be careful because you saw steam pops about 12% of the time using half normal, and more if you use just D5W. And so we ended up ablating with half normal, actually both in the AIV, again, since it was protected, and the opposing RVOT, just sort of opposite the earliest sites. And, eventually we're able to get rid of this PVC. So again, sometimes these can be a little challenging, but most of the time, mapping at adjacent sites and using these small catheters, able to have success. Again, not all the time. So that's kind of my summary. So Pvcs, we know that frequent Pvcs are associated with heart failure mortality, but sometimes they may improve spontaneously over time. The Pvcs that are wider and have more significant dyssynchrony are more likely to lead to fibrosis and cardiomyopathy, and that recovery after PVC elimination may be some residual structural abnormalities, even when the EF by echo returns to normal. We know the treatment options include watchful waiting, patients with normal heart who are asymptomatic, antiarrhythmic drugs, or we all like catheter ablation. This ABCVT score can be useful for risk stratifying asymptomatic patients. Again, I particularly like it for the low risk patients. You don't need to worry about it, and the other ones you can follow a little more closely. And again, I think typically in anyone with any kind of unusual morphology or multiple morphologies looking for delayed enhancement, and presence of scar, we'll usually do program stimulation when we bring them to the lab. And if they have inducible DT, those are patients where you might think about having a backup defibrillator, or that they might be at higher risk, even an implanted loop monitor potentially. But I think, again, we would certainly agree, hopefully more and more the world is agreeing that anyone when the PVCs tend to lead to or contribute to a cardiomyopathy, that a catheter ablation should be considered as an option for probably first-line therapy these days. These are everyone in the lab who helped with the animal studies, the echo analysis. Again, I'm fortunate that I can sort of suggest things, and the fellows all go out there, obviously, and they're doing these animal studies and doing all the work. And well, then with this, which is actually a true photograph, but this is Mount Tam, which Sanjay alluded to, is out in the distance of my backyard. And if you come out here one heart rhythm, we can take you on some trails and hike up there. You get a beautiful view of the Pacific. So I think with this part of the talk, maybe I'll pause and happy to take any questions, and then we can move on to the electroporation.
That was terrific, Ed. Very, very comprehensive and right on the money in terms of, the points that you touched on. So we have a few questions, and I'd like my co-chairs, Dr. Udayavar and Dr. Padmanabhan, as well as Dr. Yadav, to kind of lead some of the discussion here.
Yeah, hello, Dr. Ed. This is Dr. Udayavar. Wonderful lecture with very good insights on PVC mediated cardiomyopathy. I had 2-3 questions of mine. We all know that non-outflow tract VPCs are more likely to develop cardiomyopathy. So would you have a lower threshold for ablating them if you see those patients, if you compare to outflow tract PVCs?
Yeah, it's a good question. And when I'm talking to patients, there's a plus and a minus of it, right? We know non-outflow tract has a higher chance of cardiomyopathy, but on the other hand, sometimes they're more challenging. So, it depends. I would say cusp LVOT PVCs, pretty straightforward. Very high success rate. Papillary muscle PVCs, on the other hand, I think are often, more involved. Sanjay had a nice review article on ablating these, but success rate probably lower, often takes a lot of ablating. I'm kind of reluctant to jump into a papillary muscle PVC in an asymptomatic patient, or even the Parisian one. So, if you see that AVL as being positive, I think that has higher risk as well. So I think that's the balance. I generally still will not jump to ablation, for someone with even a non-outflow tract asymptomatic PVC with a normal heart, unless they're bothered by it. I think if they're really bothered, sure. If they're asymptomatic, based on that Dayal study, they can just get better with time. So usually, I'll get an echo in 6 months and a year. And certainly if you see the LV dilate, I will. But sometimes they will just get better with time. Again, I've had people where either up front or after a year, just say, if you can just get rid of this thing, I don't want to keep coming back every year and worrying about it. I want to go skiing. And, we talk about the risks and benefits, that it's not 100%, that there's some risks. And I've had people share where we've gone and done an ablation just because even though it's not clearly causing symptoms of cardiomyopathy, they're in a higher risk group and they want to just not worry about it anymore. But as a general rule, I think I've at least been impressed by this Dayal study that some of them get better with time or get better with a little beta blocker. And in general, we keep an eye on them. And again, I think the conundrum is,
Another two.
You worry about ablating a lot on a papillary muscle, and it always seems like, it's not like a one burn that's fixed. And, you're going to create some problem with MR down the road by creating, constrictions there. We don't want to create heart block in a young person. So that's the challenge, I think. If they're non-outflow tract, the ablation is always harder. It's almost easy for an RVOT where you say, it's safe, it's going to be, a quick procedure. So I think that's a challenge, but I have ablated some of them.
I had another 2 small questions. One is regarding beta blockers. What we normally find is most of the time, some of the PVCs, they disappear when the patient's heart rate is fast. And in fact, they appear when the patient's heart rate is slow. Now, these patients, normally, they don't respond to beta blockers. Now, Of late, we have flecainide and mexiletine available in our country. Earlier, it was not the case. And amiodarone being a toxic drug, we would want to avoid those drugs in those patients. So we are still tempted to use flecainide or mexiletine in some of these patients if we find that the beta blocker is not working or in fact it is aggravating the situation. So your comments on that. And the second question was, what is your idea of unipolar mapping of the substrate in PVC cardiomyopathy?
Yeah, so good questions. I agree. I mean, I think I would say beta blockers can help us you've probably seen the same, a small proportion of people. Most people, you have to get to a high enough dose of, say, metoprolol that they feel crummy. But I've occasionally put people on 25 of metoprolol and had a dramatic reduction in PVCs. And then again, my other trick, when people feel tired, is bisoprolol, or I've gone to more commonly this acid. I don't know if you have acebutolol or Sectrol. Not so commonly used, but it doesn't cross the blood-brain barrier, so it tends to cause less fatigue. And particularly for bigeminy, it just seems to work well. So I've changed people from metoprolol to acebutolol and seen some improvements. But I agree, though, most of the time it doesn't make enough of a dent in the PVC burden and just causes side effects. So flecainide, again, I think with some of the pen data, if someone's EF is mildly reduced, so it's kind of 45, 50, and they don't have any scar, I'm okay. Usually I'll use propafenone just because, at least in the US, flecainide medical legally is kind of, got the black box, and they have like a line of lawyers ready to sue you if someone has a bad outcome. So I've used propafenone, but I've used flecainide too, and just kept an eye on people. So I think that's totally reasonable. I would not use, amio in general for PVCs unless, it's an 85-year-old with, you can't, after a failed ablation or something like that. I've used it as, a short-term treatment. So if you're not sure if someone's frequent PVCs are really the cause of their cardiomyopathy, or they have a cardiomyopathy and PVCs, put them on amio for 6 months and suppress the PVCs. If their EF gets better, then, you stop the amio, and then you have more reason perhaps to go in and do an ablation. But yeah, I agree with you. I try to avoid amio. But I think flecainide and propafenone, again, I worry more in someone with an EF of 30, but if it was mildly reduced, I would use it. And then remind me of your second question.
But the unipolar mapping of a substrate.
Yeah, so again, we do a lot. We like, I don't know about the availability there. We like MRIs to look for any delayed enhancement before we go in. I think the unipolar mapping is helpful. So, we'll do a full, and we do bipolar maps, so you do both. And I'm certainly reassured, in someone who maybe has potentially higher risk and the bipolar map is normal. Unipolar mapping, obviously you have to be careful because sometimes around the valve annuli, you'll see some low voltage regions. But you can get, as you're alluding to, a hint of perhaps some epicardial abnormalities. But I tend to use the MR more, I would say, for risk stratification. Again, I think if you're worried perhaps that someone might have early ARVC, then I think, certainly, and we've done this as a diagnostic test because some people have devices, you can't, the MRs, they've got a lot of artifact. And someone where the CT, again, also a lot of artifact. So if they have a normal bipolar and unipolar map, it's usually reassuring that they don't have certain, for example, ARVC. Whereas if you see, scar at the base or abnormal unipolar map, even early on, that can be more suggestive of ARVC. So I think when I'm, the question is this just sort of an unusual basal PVC location, or could it be someone with ARVC? Then that's typically the case, is where we'll do more detailed bipolar unipolar voltage mapping and program stimulation. And, can we just reassure the patient that we ablate the PVC and they're fine, or we're more worried about someone who potentially has epicardial scar, which you may not see as well with endocardial mapping. So can be, I think, useful in those situations. It's usually when I use it.
Thank you. Deepak or Neeraj can make comment.
Dr. Gerstenfeld, we have some questions on the chat for you. Dr. Naber wants to know whether it would be interesting to your animal study with giving the lead position in the outflow tract, the site of the most common benign Pvc morphology. Would you want to place your lead there and then try pacing from there?
Yeah, so that was, with the free wall RV outflow tract pacing, we actually intended to put it in the septal PVC region, but by fluoro in the pigs, when we sacrificed the pigs, it turned out it was actually more free wall than septal. So that's why we ended up using that. Yeah, so presumably if you did a septal group, we might see less of a cardiomyopathy. Again, all these studies sort of take time and money, so we didn't repeat it with the septal group. And I see someone else thought of, what I think is, we thought of also is, what about BIV PVCs? So perhaps, we use as a control Pvcs, right, to create irregularity without synchrony. But if the synchrony is really the issue, perhaps Pvcs from bi-V pacing or Pvcs from both the RV and LV that didn't cause synchrony also would lead to cardiomyopathy. So again, we didn't do that study as sort of a control, but could be done. Again, I found a lot of these devices will have algorithms to try and pace on top of a PVC to narrow it. I think the pacing comes in too late usually. I haven't seen that that's too helpful, this pacing on top of PVCs to try and prevent a cardiomyopathy, but the device companies often put it in there. Yeah, the 19-year-old looks like the non-coronary cusp. So again, we ended up, so that's, I guess, a good call. We ended up ablating that from the right cusp. PESP, so is that, yeah.
Post-extrasystolic
Reviewed
Dr.
post-extrasystolic potentiation. So obviously after a PVC, you'll have a pause, right? So the following beat will have a stronger contraction and stronger DPDT. And that's been, one of the things we debated, is it really the PVC that's causing the cardiomyopathy, or perhaps maybe the excessive contraction and calcium overload from the post-extrasystolic beat, maybe that through, energetics is actually contributing to cardiomyopathy. So at least from our, we didn't look specifically at that, but from our data, the fact that PACs didn't lead to much of a cardiomyopathy compared to PVCs, the PACs have the same, they conduct, so they have the same post-extrasystolic pause. So from our data, at least, it's not as much the pause as the PVC. But I think that's a good point. There have been studies published that show post-extrasystolic potentiation, and it may be part of the mechanism as well. This studies looking at interpolated PVCs potentially being at higher risk. But that may be some of the mechanism that we haven't looked at it as detailed. But yeah, if you have insights in terms of the only way we've looked at it is indirectly, that the PAC group had a similar post-PVC coupling interval, but didn't get as much of a cardiomyopathy, but we haven't otherwise looked at it that critically.
Would you think that for your PAC group, the variability was not long enough for a longer period of time? I mean, you consider a classic PAC situation like atrial fibrillation, it's PACs all over. So would you think the delta that changes there, the delta that keeps changing over a period of time, that might actually lead to more cardiomyopathy?
It might. I mean, if you remember the curve, there was a slight drop. And I thought about doing, I tried, getting a pacemaker to program it so we could pace kind of randomly, because that's another whole question, right? Why do some people with normal hearts get cardiomyopathies from atrial fibrillation, as you're alluding to, versus not? There is, when we looked at the synchrony, the shorter the coupling interval of the PAC, you actually do start to get the synchrony in the conducted ventricular beat with a short coupling interval. I think it has to do with the SR, and the shorter you come in, maybe the SRs depolarizing differently in different parts of the heart. But there is some confounding where short coupled PACs can actually cause ventricular dysynchrony. But yeah, I think it's, and again, when we tried to do this with irregular pacing in the atrium, we didn't see as much of a cardiomyopathy, but I think there's probably some. And again, we don't know, I still don't know, why some people with AF, right, their LV is perfectly normal forever, whereas some people will develop a cardiomyopathy. We're looking at this now with PVCs too. We're doing, trying to do genetics in people with PVC cardiomyopathy versus PVCs who never get a cardiomyopathy. Is there some kind of mutation, heightened splicing mutation or something that maybe predisposes some people to develop a myopathy where the others don't? And my guess is there's a similar thing for AFib. So yeah, I think it's definitely possible.
Dr. Hayagreev has a question that, would you advise cardiac MRI for all patients with PVCs? And he also goes ahead to add that exercise abolishes PVCs in some patients, particularly with bradycardia. Is this adequate to treat such patients?
Yeah, so I don't have a lot of data on this, but I view it as at least it seems historically to be a good prognostic sign when people's PVCs go away with exercise, right? You run them on a treadmill, some people have more PVCs than VT, some of them go away. It seems like the more benign ones often are the ones that suppress with exercise. So I consider that a good factor. And I think the point was made, which is a good one, that there are people where beta blockers make them feel worse because they have more of a bradycardia-dependent PVC. So I haven't treated people, for example, like that with pacing just because I'd rather ablate their PVCs than have them dependent on a pacemaker. I don't know how you would treat them, but I think, there are people that seem to have more, PVC suppression with exercise. And I kind of tend to reassure them and worry less about them. But I don't know, other than, avoiding, negative dromotropic agents, or I usually wouldn't use the pacemaker to treat them.
Sounds
Right.
good.
So I think with Ed's obvious expertise in this area and the amount of interest in the audience, we could probably continue this for much longer. But I know we are all constrained by time. And so I think it'd be worthwhile if we go to the next session. But before we do that, Ed, do you need a short break?
No, I'm good. One of my house is still sleeping.
Okay. Well, if your voice is sore at the end of the day and you're tired, my apologies to Leslie, but thanks again for, continuing with this. And so I think we'll move to the next session, which is on pulse field ablation. And this is again an area that Ed's gotten interested in early on, has done some of the early work here. And so it'd be great to kind of hear his perspective on a technology that's generating a lot of interest in the EP community and the promise that it holds for us.
Okay, well, thanks, Sanjay. Thanks, everyone. Yeah, and I think, I haven't played with this yet in the clinical lab. We're about to start or get involved in the clinical trial in humans. But I've been pretty impressed about pulse field electroporation. And I think it is, 5-10 years from now, going to replace a lot of what we're doing with RF. So I do have, advisory board and the animal study supported by FARAPulse, which is one of the electroporation companies. So I just have a brief background. I think everyone's probably heard a bit about electroporation. It's been known for a while that if you apply an electric field to a cell, you'll actually develop pores in the cell membrane and increase permeability. And this has been used for solid tumors or for genetic transfer to kind of transfer molecules into cells that then will heal. But if you apply a high enough electric field for long enough, you'll create multiple pores and the contents basically will drain out and the cells will die or become apoptotic. And, that can be used to kill cells. And so the two main factors are the duration of these pulses and how strong a field you apply. So if you apply relatively short, so in general, I'll say, these pulses are in the microsecond duration, they're relatively short. If you think about defibrillation, those pulses are in the millisecond duration. So these are shorter pulse widths than, for example, if you can try and do electroporation with a defibrillator, but you'll end up with thermal as well as electroporation effects because of the pulse width. So at shorter pulse widths and lower electric fields, you'll get reversible electroporation. As then you increase the electric field, you'll get this irreversible electroporation, again, which means the cells are going to die. But if you keep increasing out to the millisecond duration, and if you keep increasing the field strength, eventually you'll get thermal necrosis. So the companies that are developing this are trying to keep things in this sort of irreversible area. And there's a bunch of different factors that go into how electroporation works. There's, usually you're giving a series of pulses because you're more likely to get irreversible electroporation if you apply the pulse multiple times. There's the pulse width that I mentioned. There's how the field is oriented. There's the actual field strength. There's the shape of the pulse, much as with defibrillation waveforms that work with different waveforms when it comes to electroporation. There's the frequency of the packets or pulses. And as with RF ablation, there's the polarity, so you can have a unipolar electroporation between a catheter and a patch on the patient's back, or you can do bipolar electroporation right between adjacent electrodes. And this is all from a review paper. I just took some of these examples. But this is just showing on the right some of these potential waveforms. So the general voltage or field strength you'll see for irreversible electroporation is between 500 and 1,000 volts per centimeter. You can kind of push this maybe up to 11, 1200, but if you start getting higher, up towards 1500, 2000, you'll start getting thermal effects or arcing across electrodes also. So that's kind of the sweet spot. And then again, you can see that this train of pulses is usually around 100 microsecond range. But for example, you could have a train at a 500 volt per centimeter field strength. You could have a stronger 1,000 volt per centimeter field strength to make a bigger lesion. And companies have now mostly switched from, kind of like with defibrillation, from monophasic to biphasic waveforms that seem to be more efficient for delivering energy. Again, if you want to make a smaller lesion, you can make the pulse width shorter, and then people have played with exponential decay. So that's all sort of the biophysics that the companies deal with to eventually come out with a product. And none of them will tell us exactly what their electroporation numbers are, because that's kind of their secret sauce that they're doing to develop their ablation approach. But the nice thing about electroporation is, one, it's quick, and it just really seems to I think it's one of the things we just got lucky with. We got lucky, we got unlucky in some things, right? It's unlucky that the esophagus is right behind the left atrium, but the lucky thing is myocardial cells seem to be exquisitely sensitive to electroporation. It just can wipe out the cells with minimal, coagulum or thermal effects. And and I'll get into the details of this, but a lot of studies have shown that much less sensitivity to non-myocardial cells. So people have electroporated directly on the esophagus or nerves and shown no damage. So, the potential is for a rapid, safer ablation. And, obviously this is being looked at pretty intently for AFib. Vivek and his group and PRJs are looking with Farapulse at electroporation for AFib. And Farapulse is about to launch, a multi-center randomized trial comparing RF ablation to electroporation for AFib. So they have this flower-shaped catheter. It's over wire catheter, and it can be either flattened out or expanded into sort of a mini basket. This is the pictures on fluoro. I've used this a bunch in the preclinical in the animal lab, and we're looking forward to hopefully starting in March with patients. But again, this is sort of the delivery. So as opposed to, whatever you're doing now for RF, I think it's shorter with high power, short duration, but it's a 2.5 second packet, 5 packets of pulses, again, in the microsecond range. And you will just rapidly eliminate the voltage around these pulmonary veins. It's not one application per vein, because there's this flower and you want to rotate it. So I think in general, they're doing sort of 6 to 8 applications per vein. So you can do some as the flower shape, or depending on the vein size, you can enlarge it and make a little mini basket out of it. But again, even 6 to 8 applications of 2 seconds each, that's 12 seconds. And after manipulating the waveforms, they've moved over time from monophasic to biphasic to bipolar. With this early data, and they have more patients now. I mean, this was back when they had published it with 80 patients. I think they're up to, in Europe and Prague, over 120 patients. They were able to achieve pulmonary vein isolation 100% of the time in about 30 minutes of left atrial time. The whole procedure time of 90 minutes included mapping pre and post. So, and again, this is done just with fluoro. There wasn't really any mapping system. And in the patients they've remapped with this latest approach, I think it may be 98% now, but they found basically that 100% are durably isolated. And when they've looked at the esophagus, they haven't seen any esophageal damage, any pulmonary vein stenosis, or any phrenic nerve injury. So, I think we're real excited to play with this in humans, because it really has, I don't know, we're going to have to be able to improve our lab turnover time, because the procedures are taking 45 minutes to do pulmonary vein isolation, and you don't have to worry about the esophagus. So I think it's the first time we've really gotten lucky with an energy source that may really change the way we do ablation. But I've always, been interested in VT, and everyone's interested in AFib. So I managed to convince the company to say, what if we brought the catheter to our lab and tried to look at how this worked in the ventricle? I mean, maybe we could make, safer, bigger, deeper lesions in the ventricle and not be stuck as we do making, point-to-point lines. And, the safety aspect in terms of not injuring arteries or nerves also is potentially interesting. So there were 3 different catheters we played with in the animal lab, or had the fortune to play with. One is what they call this FireFlex. It's, again, sort of a mini basket. They developed it really for making kind of posterior wall isolation or linear lesions in the atrium, kind of for mitral flutter. But it's got 10 electrodes. It's, can be shaped into a mini basket, and you can, the electric field then is bipolar, so it's kind of rotated among all these electrodes to apply the application. It's a 12 French catheter, and it goes through it's not really steerable, it goes through a 17 French steerable sheath, so a larger sheath. They also, we asked them to make, but they were working on it anyway, of course, a focal catheter, because again, maybe we can use this for all sorts of things, maybe AV NRT. So this is they call the FirePoint, which is an 8 French linear catheter, has 4 electrodes, and at least in its present form, the electroporation is, again, bipolar among all 4 electrodes. You're getting it all along the length. And then we figured we would do irrigated RF ablation, just sort of as a comparison. And again, I think, they've done a lot of preclinical studies in kind of normal hearts and what kind of lesion they can see. But what I was interested in is, how does this work in infarcted tissue? Because once you have damaged fibrotic tissue, we know that RF doesn't penetrate as well, and maybe this could be an advantage potentially for electroporation. So we took 6 swine. We created an infarct with 120-minute balloon occlusion of the LAD, and then survived them for a month. We did voltage mapping to identify the infarct in the border zone, and then either gave electroporation or RF via transeptal puncture to dense scar border zone and some areas that were healthy. Again, the PFA was this bipolar, biphasic microsecond waveform range. The max they gave us for the point was 1800 volts and 2000. It's not really adjustable. They had a big generator, and that's what it gave. So 2000 volt field. If you remember, I said the fields vary between, say, 500, and you can go up to 2000. And they were the 2.5 second application. So it's a train of packets over 2.5 seconds. And we did 4 lesions per site. So again, 10 seconds basically for each ablation site with PFA. I wanted to try and make as big a lesion as I could with RF as a comparison. So we would start at 35 watts and basically, crank up to 50 for 60 seconds, but basically trying to achieve more than 10 ohm impedance drop, which we typically did as just a comparison. And then we infused TTC, which stains normal myocardium so that you can see the lesions. We actually gave the hearts a week in formalin and then sectioned them and looked at the lesions we made. And this is just some examples from the hearts themselves. So again, this is the LV kind of short axis. This is the infarct, which typically is kind of an anteroseptal infarct in the pig heart. And, again, I think you can see this is the FirePoint and this is the FireFlex. So this is a lesion, kind of in or in the border zone. And, this was a lesion in healthy myocardium. You can see the heart's very red because we've given the TTC, so it really outlines the lesion reasonably well. This is the same thing with that FireFlex. You can see a lesion out laterally and a lesion that we've delivered kind of in the infarct. So I showed some of these, if you saw them at the VT symposium. There's always a lot of info on these slides. So on the left is just the, so this is the Farrah point, the focal catheter. This is kind of where we made out the catheter was likely sitting when we delivered the lesion. The voltage from the proximal and distal electrodes, it's pretty impressive. You know, you give 2.5 seconds and the voltage is just gone. It really dramatically decreases. This is the voltage map, by the way, in the lower right. So it's an anteroseptal infarct, and this is this location. So this is kind of an apical septal application. This is the fluoro, sort of an LAO with this catheter in the apical septal region. And so what, you know, a pathologist, we had a pathologist painstakingly do, because it's a little hard with these lesions since they're non-thermal to differentiate normal tissue from electroporated tissue. So they looked at side-by-side H&E at high power along with this trichrome stain. I'm just showing the trichrome. And what they did then was outline in yellow the area that's just infarction. You can see the fibrosis in blue. And then in green were the cells that were electroporated. So there's certain histologic hallmarks of contraction band necrosis and cellular nuclear pycnosis that the pathologist can identify that say these cells have been ablated. So in yellow outlined here is the infarct, and then green are cells that were not infarcted but ablated by the electroporation. And we tried to be conservative, so we, you know, they wanted to measure the distance to wherever we saw a lesion, but we kind of forced the pathologist to just measure from the tip perpendicular to the greatest extent that we saw of electroporation. In this case, 4.6 millimeters. But what was interesting is, you know, you can see these islands of surviving myocardium within the infarct that we know happened and we know cause VT, but they were really completely ablated by the electroporation. And we often got beyond the infarct to get to some of these areas. We can debate, you know, the question is, some of these areas are pretty far away. So this little island out here, you know, it's like 10, almost 15 millimeters away. And, you know, there's some debate is that because the living cells tend to channel, you know, the electric field tends to preferentially head for surviving cells. It could also be, again, the heart's obviously moving or electroporating from the proximal as well as the distal electrodes. So there may be some far field effect. But that's an example with, this is another focal lesion. Again, here's the ablation catheter. Here's the voltage pre and post. This is a little bit higher on the septum, kind of mid-lateral. And again, we see the infarct, and we've gone pretty much transmurally. So there's a little sliver epicardially of surviving myocardium. But those cells, the pathologist tells us, were electroporated, and as well as some of the surrounding area. And again, this is with 10 seconds of application. This was in a healthier area, so a little bit of fibrosis, but I just thought I'd show what a lesion. And again, you can see it's a little hard to differentiate it visually, but actually we got 7.3 millimeters deep, which is a pretty good sized lesion in a relatively healthy area. This is this Fireflex, which is this basket shaped catheter. Again, you know, here you can see the infarct. And what's nice is we got not only able to electroporate the cells within the infarct, but even beyond the infarct on the surviving epicardial layer, we were able to get almost 7 millimeters deep. Again, this is different animal, kind of mid-septal, and this is the fluoro, kind of showing what it looks like when you put this catheter is going through there. So it's transseptal 17 French sheath, and then this ablation catheter. This is, again, higher up, similar, able to ablate the endocardial cells as well as get some, not full thickness here, but some tissue deep, as well as the surviving endocardial layer. So just looking, and we actually are up to about 10 animals now. I think the fellows are working on the data for the heart rhythm abstract deadline. But this was the preliminary data looking at, there wasn't much of a difference between the focal and the flex, the focal catheter and this basket shaped catheter in terms of lesion depth. And it was actually quite similar. There are studies showing that RF doesn't work so well in infarct, but we were able to get, you know, similarly sized lesions. So it wasn't necessarily deeper by statistically compared to RF. And then I compared PFA that was in healthy tissue, because the question was, again, are we penetrating as well in infarcted tissue, and RF in infarcted tissue? So we were able to get similarly deep, and it was a little, in healthy tissue, you did get a little bit deeper on average than in infarcted tissue. But, again, so even though the PFA wasn't necessarily deeper than we saw with RF, it was pretty quick compared to RF. But it seems like, these catheters both perform similarly. The Faraflex, I should say, it's hard to measure width, but lesions were a little longer based on the catheter, but not necessarily deeper. And, the limitations of, obviously this is in swine with small numbers. What the company always wants to emphasize is they really didn't develop this for the ventricle. I kind of had to convince them that it was worth the time to try it in the ventricle, because, AFib is a much bigger market than VT, obviously. So it's possible if they actually try and fine tune the waveform for the ventricle, that we could even make bigger lesions. And again, the lesion measurements were pretty conservative. We just took perpendicular distance from the tip. But if you took the furthest distance, they would be even deeper. So, our conclusions from this little work were that it's PFA of myocardium in-around infarction is feasible. Myocardium, both within and epicardial, was to the infarct, was successfully ablated. It's pretty quick with lesion depths up to 7 millimeters. We didn't see any differences between the flex and the point catheter. And again, I think everyone's excited about ablating AFib, but I think it has a lot of potential for VT. And I think it could replace a lot of what we do, honestly. I mean, imagine, it's the conduction system also is relatively refractory. Purkinje cells are not ablated as much. They can be at high energy, but not as much by electroporation. So, maybe you could ablate a Parisian attack with a focal electroporation catheter, and it's pretty quick and non-thermal, and you have less worry about collateral structure. So, I'm sure we'll learn a lot more as we take this to humans. But I'm pretty excited to think of all the energy sources. We've looked at our lab at HIFU, at high intensity focused ultrasound. This is so far, I'm sure we'll find some problem, but it seems to be pretty impressive. These are kind of the folks from Farapulse and the pathologist, and our lab has done these studies. So I think it's gonna evolve pretty quickly over time, but I'm happy to take any questions that people might have on electroporation.
Again, that's terrific. I know it's a lot of talking that you've done, and we really appreciate the time that you've given the audience this morning.
As you know, I don't do a lot of talking at home. My wife does. So
that's not true. That's not true at all. So don't go around disparaging Leslie, okay? Because I will text her right now, should you do that once more. So, no, but thank you again. So, yeah, I think there may be some questions for sure. I think there was one that just came through in the chat. You probably see it too. What would substrate ablation with electroporation do to the LV function?
Yeah. I mean, so again, if you look at the data, at least, they may get better, but, the lesions are similar to RF. So I think the key is, that you restrict what you're ablating to surviving islands within the scar. And if you're ablating within scar, in terms of, ischemic cardiomyopathy type of ablation, hopefully you won't have any more effect than you've had than we see with RF. In terms of other potential approaches, like I mentioned, AV&RT or pathways, again, for this study, we were, in the ventricle for the first time. So we were trying to make as big a lesion as possible. But you could certainly imagine, if instead of all 4 electrodes, you just electroporate from the distal 2, and, it depends. These companies always say they can't do it. They say they can't easily vary the energy, but you could have like RF, we go from 20 watts to 50 watts. If you can bring your pulse field down to 1,000, you can probably make small lesions. So I think there is the potential to fine tune it for other areas of the heart. And I think with an infarct, again, you just want to, if you restrict it to the area of infarct, hopefully we won't have an impact. I've tried in some recent studies. I was curious about the papillary muscle because that's, papillary muscle PVCs are always a challenge. And, most of these were healthy papillary muscles, but it's pretty impressive lesions you can make. So what makes me worried about electroporation, honestly, especially as we start, in the atrium, we're starting with controlled studies. You can only do PVI, but it's pretty easy to wipe out large areas of the atrium. So, the posterior wall I've done in animals, you just basically take this flower basket and you just put it 1, 2, 3, 4, and the posterior wall is gone. I mean, you go from, 2 millivolt electrograms to nothing. It's pretty easy. And so I do worry, there's certainly a trend for people, because we don't understand really the mechanism of AFib, to want to ablate more. And so I do worry that as this tool gets out there, people might kind of blast away at the atrium, not really understanding what they're doing. So it does have the potential to ablate too much. But again, I think we have to, take small steps and stick to the areas that we know are causing problems. But I do worry a little bit that you can really ablate a lot of tissue, and in the atrium, you're getting full thickness lesions everywhere.
Along those lines, Ed, there is another question about the pro-arrhythmic effects. Have you seen anything to suggest that may be a concern?
Yeah, again, we've only done it so far in pigs in the ventricle. So during, I don't know if you've worked with pigs, but they tend to be very sensitive to RF. So it's not uncommon, for example, towards the end of a 60-second RF lesion, and we actually give them amio ahead of time and lidocaine during the study. But occasionally, I think, out of the 16 lesions, maybe 4 of them we had to defibrillate the pig at the end because RF tends to be irritable. And we haven't really seen that with electroporation. We've seen ectopy. So during the actual electroporation, we see some PVCs, but it's so quick, it's 2 seconds, it kind of just comes and goes. You will see some, muscle contraction. So you'll see the muscle spasm. For the human AFib studies, they're actually doing it under conscious sedation. And they feel like with enough propofol in their experience, you're able to sedate people. And it's one of the advantages actually of the biphasic as opposed to the monophasic waveform, is you get less skeletal muscle stimulation. But you will see both skeletal muscle as well as phrenic. We're used to being nervous when you see phrenic, but you'll see the diaphragm jump briefly. But again, all the studies so far have not shown any injury to nerve, but you'll see those effects. Again, you'll see some PVCs during delivery. So it's possible you'll see some, we've only done in pigs, we haven't seen, late pro-arrhythmia, but you can see some ectopy during delivery. But it's so much quicker than RF. You see ectopy, right, ATAC and VT where they're ablating with RF too. And because this is just 2 seconds, it tends to just come and go. I haven't seen it cause a big problem.
Ed, that was terrific. It's getting late in India right now, and I know your side of the US, I think the family is probably going to be waking up. So
the sun's rising, you can see behind me.
Sun's rising, there's your backyard. I don't see the grill there. Looks like you relocated it from. But yeah, so guys, if you step into that backyard that you see in the backdrop of Ed's living room, and literally right there is where the redwoods start. And then just a never-ending trail all the way to the Pacific. So he lives in heaven, and I'm glad that we were able to both tap into his extensive knowledge base and also get a sense of why he moved to where he is now. So Ed, thanks again. This was terrific.
And again, if anyone,
Dr. Sanjay, if Ed is not very tired, I would just want you to take another question. There is one question from his previous talk, which Dr. Yash had asked.
Yes.
Has been left in the chat box, please.
I'm fine. I was going to say, anyone, email, feel free to contact me anytime, but go ahead.
Okay.
So I think Dr. Lokhandwala, who, by the way, is on this chat, and he's the president of the Indian Heart Rhythm Society this year.
Yeah, we met before. I think thanks, for the invitation. I think I talked a little bit at the Indian Heart Rhythm meeting.
And he actually originally trained with Dr. Wellens, so one of his early proteges, who came back to start EP in India. So, so he actually, I'm glad that you did this talk, because just a few weeks back, he had expressed his opinion about PVC ablation and how it's kind of done without the thought process that needs to go into really deciding which patient is going to benefit. So I think this is very appropriate, the discussion we've had. So he, I think, asked a question related to the 19-year-old, the position of your catheter.
No, Sanjay,
I'm sorry.
My question was more, I was very impressed by the data, the Canadian data about the normal hearts and the PVCs. And it seems 44 to 50% of those PVCs disappeared over time. So if you look at this, then I see a lot of normal heart PVCs being ablated in workshops, so isn't it more sense to just wait and watch then with these normal heart PVCs?
I agree. I mean, I saw a consult recently from someone with normal heart, had like a 30% PVC burden. It was LVOT, and they actually had ablated the left bundle with a Parisian PVC and not gotten rid of the PVC. And so then they sent him to me for another attempt at ablation. And I'm looking at the guy, so now you're ablating potentially from the right, to ablate his right bundle, right, is done in terms of conduction system. And he was asymptomatic with an EF of 60%. And I kind of said, I don't think we need to do anything, but maybe just keep an eye on your EF now that you have a left bundle. He's totally asymptomatic. So I agree. I think I maybe was a little more aggressive early on because it's fun and you worry and it can tell people, oh, you might develop a cardiomyopathy. But I was impressed by that data too. So I have for an asymptomatic person with a normal EF, we'll do sometimes, an MRI. I didn't answer that question. I like to MRI most people just because we're collecting data. But again, I think a young person with a typical alpha tract PVC, I don't usually MRI, but anyone with more than one morphology, or if it's a Histian or papillary muscle or unusual morphology, we'll typically get an MRI on. And if they're asymptomatic and their heart's normal, I think following them is perfectly fine. I agree. I think we all want to go in and save the day. But as you know, as we all know from doing this, complications happen even in the most straightforward procedures. So you can always cause some harm. So I agree.
And I was
go ahead, please.
Sorry, I just glad you made the point that the whole fear of cardiomyopathy because of PVCs, which has been raised. But I'm very glad you made the point that it's not suddenly falling off a cliff. It's something that you can always wait and watch and tackle as it comes. There's no hurry. There's no need to create fear among the patients and the family for PVCs. That unless, of course,
I think
I'm
that's
talking of structurally normal hearts.
Yeah. And what we often look for is increase in the dimensions, right? Which you'll often see before the drop in the EF. So if we see the LV start to dilate in a young person, that may make us more worried. But again, I think we still need to learn more, right? I mean, we've all seen this, right? We have people with 30% PVCs I followed, for 8 years, and the EF is completely normal. And then there's some who have PVCs, in 6 months. I think the Parisian PVCs, because they're so narrow, are less likely to cause a cardiomyopathy. That young guy was unusual, but most Parisian PVCs, I reassure because I think they're less likely to cause a cardiomyopathy. It's the wider ones that are more likely. But I think we still need to figure out, why is it that some people will develop a cardiomyopathy and some don't? And, is it some genetic predisposition or some other reason that predisposes them to it? But I think they're all make good points.
So, Ed, you had mentioned.
I would also like to, Sanjay has done a great job, putting this together, and you've woken up early morning. But Sanjay with Vanita has really put in a lot of interest and takes a lot of effort to put this all together. And we're all on the base of IHRS really, would like to thank Sanjay and would hope that he doesn't tire in these efforts, because we are really learning thanks to his enthusiasm and effort.
Well, thank you for that. No, we will very much want to continue this, and I hope we can expand it to now the next stage where, people like Ed, who are, such avid investigators, can be interested in partnering with centers in India to set up collaborative multi-center experiences. I think that would be one thing to consider. Also, as I said, and Ed, I spoke before you came online about how California is probably one of the few states in the US where I think fellowships are still allowed for people who have trained overseas to come and join for EP training. And, that's another collaboration that, our Heart Rhythm Society in India, the trainees can benefit from. So I really hope this takes a life of its own.
Yeah, no, would love, again, obviously we're always, limited by what we can do as a single center, or, volume, I would say, is moderate. It's probably not as high as Penn's or other centers. So we're happy to collaborate. And yeah, some of our best fellows and most productive have been the fellows from abroad. Mainly we've taken fellows from Australia, Canada, but we're allowed to, there's some paperwork, but we're allowed to take, English speaking fellows from abroad if we go through the paperwork. So if people are interested in even coming out for an advanced year or additional training, we're happy to talk. And we also have people who come out and do work in the animal lab for a year or two and publish a lot of papers, hopefully. So thanks, Sanjay. It's been great meeting everyone. And again, you guys welcome to come to California. Sometime I'll have to actually get out to, I've always threatened Sanjay is going to have to show me around India as well, so I can get out and visit you once this is all.
I think down. the next time there's an HRS in San Francisco, I think we should all have an IHRS walk in the Redwoods.
Absolutely.
Yes.
We look forward
through Sanjay. That sounds fantastic.
Yeah,
I'll bring the cigars and
we can grill afterwards.
That's right. Well, this is awesome, Ed. Thank you again for waking up early, for doing this. My apologies to Leslie, because I know you're going to be tired for the rest of the day and you'll make excuses to not go trekking today, but I'll take that on my chin. And thank you for everybody in India for kind of, making time. And I hope it was worth sparing your evening to hear Ed share his knowledge with us. Thanks very much.
Thank you. Thanks, everybody.
again.
Thank you so much. Thank you so much. Good night and take care. Thank you,
All
Dr. Sanjay, once more.
Yep. My pleasure. We'll chat again.
Yes.
Okay.
And we will continue for March, April, May, June, as you had planned.
Will try my best to line those things up.
Sure. Sounds great. Sounds great.
All right. Take care, guys.
Take care. Thanks, Sanjay.
All right, Ed. I'll talk to you again.